joining us for today's webinar on accurately measuring height and weight in pediatric patients. Today's presenter is Dr. Jennifer Gross from Blank Children's Hospital, and because this webinar does have CMEs and CEUs, I do need to tell you that Dr. Gross has nothing to disclose as far as commercial relationships with any vendors. In addition, because of our CEUs and CMEs, each of the site coordinators was given a sheet, an attestation sheet. Please fill those out so that we can provide you with credit and email those back as indicated in the handouts that you were emailed earlier today. So with that, I'm going to turn it over to Dr. Gross.
Sounds good. Thanks everyone for joining us today. We're excited to kick off our 4-part webinar series today for the IMS 5210 healthcare program. And if you have any questions throughout, please fill those in the chat box. Becca's here with me today, and she will be moderating those questions, and we've left time at the end for any questions that you have. So let's just start by reviewing our objectives today. First of all, we want you to understand the appropriate choice of growth charts based on age. Furthermore, we'd like you to describe 3 important components in obtaining accurate pediatric height and measurements, and then describe 3 important components to obtaining an accurate pediatric weight measurement. If you have any trouble hearing, please again enter that in the chat box, and Becca and I can make modifications so that you're able to hear everything all right as well. So starting with growth charts, between the ages of 0 and 2 years of age, it's recommended that we utilize the World Health Organization, the WHO growth charts. And then between the ages of 2 and 20 years, it's recommended that we utilize the CDC, or the Center for Disease Control growth charts. Additionally, we want to make sure that you understand that there are extended BMI charts for children. So those children whose weight is and BMI are above that 95th percentile, it can be difficult to ascertain are they increasing or decreasing. And so this extended BMI chart allows you to better define what percentage they are, if they're over the 100th percentile BMI, 110, 120th. And so it's a helpful chart. And if any of you are on the EPIC system, I know our EPIC system at Unity Point does allow us to visualize that extended BMI chart. So if you're looking at your charts and your growth chart, there's a little box in the upper right-hand corner that tells you which growth chart you're utilizing. And I think most defaults are defaulted so that if they're 0 to 2, the first chart that pulls up is the WHO. If they're 2 and above, it's the CDC. But if you unclick there's a little box that you can unclick the check mark on, and then it will allow you to change between different growth charts and get access to those extended BMI charts, depending on the EPIC version that you have. Furthermore, ethnic-specific growth charts are unnecessary. So the growth charts that we have recommended above are the ones that are utilized by all pediatric patients. We also want you to be aware that there are condition-specific growth charts that should be used in addition to the WHO or the CDC charts. There are specific growth charts for children with a number of different genetic syndromes, and these are the ones that I know are, pardon me, that are available in the EPIC system, and I know depending on your EMR, you may have access to additional growth charts as well, but they're helpful in comparing those children with other children with similar genetic syndromes. And then finally, it's important to remember that their spot on the growth chart is important, but also important is their change in growth over time. So it's not necessarily exactly where they're at now, but where are they trending? And so make sure we're remembering that when we're considering their growth charts as well. Furthermore, growth charts can be confusing not only for providers, but also for the patients and families. And so the American Academy of Pediatrics Iowa chapter and First 5 in our state have come together to develop a series of, they actually have 3, it's a nutrition series of videos, and they're available on YouTube, and I put the link here. At the end of the webinar, I'll go ahead and play this video through, so if you'd like to stay on after the question component, I'll play this video just so you can preview it and see if it's something that you might like to pass on to your patients and families, or play if you have opportunities for them to view things while they're waiting for you. But I think they nicely describe growth charts and kind of simplify a complicated issue for patients and families. So let's move on to measuring height. First of all, we'll talk about instrument and preparation. So the recommendation is that we don't use the floppy arm devices that are mounted to weight scales, and I've got a picture of those later on. The gold standard is to use the device called a stadiometer, and you can see a picture of it here on the right. It's a wall-mounted measuring device that then has two components: a firm surface for children to stand on the bottom, and then a movable portion up top to be able to accurately measure their height. And so the necessary components are a flat, firm, uncarpeted surface to stand upon. If you do have carpet and you have a firm surface attached to your stadiometer, then that takes care of the issue. Some stadiometers don't have this bottom wood piece as appears in the picture, and in those situations, it's important that you make sure that there is an uncarpeted surface, so there's not that variability with the compression of the material in the carpet. There's a vertical surface to stand against, so it needs to be mounted to a wall that a patient can stand with their back straight against. And then there needs to be the movable horizontal headboard at a 90-degree angle to the surface. And then the measuring device attached to the wall, it's best if it measures in millimeter increments so that we can really narrow in on the actual height.
Oh my God, so I asked Carly to play this song.
And then furthermore, it's important to check the calibration of that device, just like anything else, with a rod of a known height to make sure that you're reliably able to get the correct measurement of that known,
the other night when she heard me talking to
the known height of that rod on a consistent basis.
Crying and it came to her, so she
and
did
it's
it for me
important
and
to check that from time to time on a regular basis to make sure that it's still in good working order and you're getting accurate measurements.
Like a dam broke. I mean, I'm really crying.
Excuse me. Can someone please mute?
That's an overview of the equipment that's necessary.
Your phone.
And then moving on to the procedures. So it's important to have the patient stand straight with their weight equally distributed on both feet and their back against the measuring device. It's best if their heels are touching each other and they're touching the wall. So a lot of kids will stand on there and get on their tiptoes because they want to be bigger than their brother or sister, and so it's important to pay attention to where are those heels and are they touching the wall and touching each other. Additionally, when you're looking at them standing up against the wall, it's best if you make sure that 2 to 4 points at least are touching the wall. So their heels should be touching, their buttocks should be touching, and then their shoulder blades should be touching, as well as the back of their head. It's important to instruct the patient to let their arms hang freely at their sides with their palms facing their thighs, and to remind them that they can continue to breathe normally. They don't need to hold their breath. It's important to remove any barrettes or hair ornaments they have, as well as undo any hairstyles on the crown of their head that may add to their height. And then an additional important thing to remember is the positioning of a child's head. And so it's important to understand this Frankfurt plane position. And so I've got a couple of slides that'll describe exactly the Frankfurt plane a little bit more in depth just to follow this slide. So once you have the child with the 4 points touching the back, their heels are touching and they're together, they're relaxed with their arms at the side, they're breathing normally, then you can go ahead and lower the horizontal plate on the top of the head and measure their height. It's important to have the child wiggle and step out and then step back in, get back into position and remeasure. So it is time consuming to get an accurate height, but it's important, it is an important step to measure it a couple of times because it can be difficult to get a child in the correct position. This is just some information about the Frankfurt plane. You can see that the Frankfurt plane is this line that's drawn from the ear to the lower margin of the orbit, and it's important that that is parallel to the floor. So the lower margin, so sometimes it's helpful to actually feel on yourself the lower margin of your eye socket. You can see where this little dot is, if you can feel that lower margin of your eye socket, you want to draw a line straight back there to the top of your tragus. So the tragus is the little part above your ear, and so that little notch between where the pinna starts and the tragus begins is the end point for that line. So that needs to be a parallel line to the floor. And so once the child is lined up in that position, then you know that their head is at the appropriate angle to get an accurate height. And this is the difference between when a child is lined up and the Frankfurt plane is in the correct position on the left here with the check mark and the A image. You can see that that child is looking straight ahead, and that actually allows that Frankfurt plane and those two end points to line up in a parallel fashion to the floor. But in image B, you can see that many children, when we're measuring them, they are shorter than us, so they are looking up at us, even though when we say look straight ahead, they look up at us and they feel like they're looking straight ahead. So you want to pick out a point across the room that's at their eye level, so that they're not looking up at us and distorting that Frankfurt plane, because that then changes the angle at which we measure them and can affect our results. So again, it's kind of a subtle difference, but it's important to pay attention to these details to be able to be consistent from time to time that we're getting accurate measurements in their height. And the reason for this is that we know that small changes in height, when we calculate the body mass index, it's the body weight divided by the height in meters square. And so small changes in measurements can make a big impact on where they fall in that BMI plane and the recommendations that we have for them in the clinic. So it is worth the effort. So finally, once we get them in position, we measure them. It's important to read the measurement at eye level and complete it to the last millimeter when we're documenting those heights. And so sometimes if you have a tall patient, you can't be at eye level to read the numbers on that measuring stick behind the horizontal board. And so we actually have a step stool in our office next to that, so that the patient is taller than our nurses, they can actually get up to the height of that horizontal board to accurately read that measurement. And they actually recommend that we take 2 to 3 measurements. So we do it, we repeat it, and perhaps even repeat it a third time, and then calculate the average of those measurements. And then document that height in centimeters in the patient's medical record. And it's best to do that immediately to reduce the error that we'll forget a digit or we'll record it inaccurately. So there's a lot of steps that go into taking an accurate height measurement for children, but it's worth the effort, and it's not without challenge. So we've all tried to measure a wiggling kid or a crying child, and sometimes we just have to do the best that we can, and so take that into account as well. So to measure length, this is preferred to measure a length on a child who's less than 2 years of age. So actually the WHO chart for children 0 to 2 actually includes length measurement. So when we put a height on that length chart, we're actually, the chart is based on lying down length measurements. And so it's important to be consistent. Are we measuring a length or a height? Because those are different based on the difference that gravity. It can be a small amount, but it can make a difference. So again, when we're measuring length, we want to make sure we're removing all clothing. And for younger kids, they can be in a gown, but for the babies, usually we remove all their clothing and remove or loosen the diaper. Remove all hair ornaments, and again, undo any hairstyles on the crown of the head, and then cover the length board with a thin paper cloth. And it's important to remember that 2 people are actually required to do the length measurement. So in our clinic, many times we'll have the parents assist, but sometimes they're not able to, so we may have to pull in another nurse to help get an accurate length measurement. So you can see the length board. It has 2 firm, kind of wide platforms that we can put the child's crown over their head against and their feet against. And so the mini scales will come with length measuring devices on them, but there's a lot of give in those. And we actually just got a new scale in our clinic this week, and they had those linked devices, and it was amazing to see the difference in the results in our heights. And so we immediately asked for our length. Someone had not realized that we needed to continue to use our length board and was going to try and just use those devices. And so it's important to not use those attached length measurement devices, but have a standalone length board to get accurate measurements on children. And so the technique for this is to place the infants on the length board in the supine position, assist the parent in holding the crown of the head against the headboard. And again, you do have to pay attention to the Frankfurt position in this position as well. They should be looking straight ahead at the ceiling and lining that line so it's actually perpendicular to the ground then in this position. The lead measure then fully extends the body, placing one hand on both knees to extend the legs, and then ensure to the best of your ability that the infant remains in the proper position, and then move that footboard up against the heels of both feet, and then read the measurement, complete it to the millimeter. And again, it's been recommended that we measure them 2 to 3 times, repositioning in between, and then using the average value of those measurements. And so there are some special circumstances to be aware of. There are certain children, depending on their body habitus, that may not be able to get 4 body parts in contact with the back of the wall. So sometimes children that have obesity, you may only be able to get 2 points of contact against the wall. So do the best you can. 4 is kind of the gold standard, but at least 2. I apologize for that. I think we're back on. Let us know if you can't hear me. Just type it in for Becca, and she'll let me know. All right, so we were talking about special circumstances. Again, 4 is the gold standard, at least 2 points of contact. Additionally, some kids are knock-kneed, and so their feet are slightly, so that it's difficult to get their heels together. So if that's the case, you want to separate their feet slightly so their knees are touching, but not overlapping or bent. Sometimes you have a child with a leg length discrepancy, and so for those children, it's important to stand on a block or a book with the shorter leg so that both knees are fully extended. And for length measurement, you want to measure to the heel of the longest leg. Additionally, sometimes children have low-set ears if they have certain genetic conditions. And so in this position, if the ears are malaligned, it's important to focus on that their eyes should be looking straight forward if they're height, or straight up if you're doing a length measurement, rather than that Frankfurt plane, because that's going to be a distorted measurement based on the malalignment of the ears. And then additionally, some children have spasticity or contractures or other musculoskeletal problems and can't stand alone. And so if this is the case, measure the side of the body that's unaffected or less affected. I just included these charts on normal growth rates for your reference. Again, we really look at how they're growing on the growth chart, but sometimes just having a general overview of what is normal growth can be helpful too, so that's there for your reference. And this is just an overview of what our normal growth rates. If you can see on the left-hand side of the chart, it measures the height gain, so how quickly are they gaining centimeters per year, and then their age over time. So you can see that when they're first born, they're growing very quickly. That rate then declines throughout the first 2 years or so, and then further declines until they reach puberty, and then they go through their pubertal growth spurt. You can see how this varies in the boys, the blue line versus the pink line for girls. All right, so let's move on to measurement of weight. When we're measuring weight, it's important that we have the patient remove their shoes. Additionally, assist the patient in removing any extra clothing or heavy things from their pocket. And I do think we mentioned before on the height measurement that it's important that we have them remove their shoes, but just to make sure that if it wasn't included, that they do need to remove their shoes when they're measuring their height. And then we need to select an age-appropriate scale. So for infants, the scale at the bottom, either digital or the balance scales are the gold standard, and then for the older children, scale that they can stand on. Now you can see on the scale on the right, there's a floppy arm device attached to that to measure height. Again, that is not recommended for accurate measurements of height to utilize that device. It's also important to consider the maximum weight that your scale can accurately measure, and make sure that you're sensitive to the needs of your patients that you're serving, and have a scale that can accommodate all sizes of patients in your practice. So once you've selected the appropriate scale, turn on the scale and make sure that you've zeroed the scale and allowed it to come to zero, and then have the patient step on the scale squarely to the scale surface. The other thing that I'll mention here is that it's not as sensitive to measure a child's height as it is to measure their weight. And so we have an upcoming webinar on weight stigma, and one of that components of minimizing weight stigma that patients experience in our clinics is to be sensitive in the workflows that we have around measuring weight in our offices. And so I'll talk more about it during that webinar, but I want to mention it here. It's important to develop workflows that increase the privacy as much as possible when you're measuring the child's height and weight. Sometimes you can ask the child if you can stand, give them the permission to stand facing or away from the scale. So if they don't want to see their weight, they don't need to, and just give them the permission that they don't need to. And then also not discussing or announcing the results of your measurements in the weight room if it's in a more public space, and reserving that until you're in the privacy of the room. When you're measuring weight, it's best to measure to the nearest 100 grams or 0.1 kilograms, and then document that weight in kilograms in the patient's medical record. And then it's best to document as close to the time that you're taking the measurement as possible, and then report any abnormalities to your provider. And special circumstances, sometimes the patients are older but unable to stand, and then you have to be a little more creative depending on the scales that you have available to get an accurate weight. The best thing to be is consistent, and so if you have an opportunity in your EMR to document, if you had to make modifications from your standard approach, to document how you did that so that you can have some consistency from one measurement to the next, because then you're looking at that rate of change over time, which is important to pay attention to. You know, many patients are scared and clinging to parents, and so that presents its own circumstances, and so trying to do the best you can, but then if it is a situation where they're scared, making sure you're documenting that so we can take that into account when we're evaluating those points on the growth chart. If they're wearing a cast or brace, of course that's going to affect their weight, and so documenting that difference. And then again, having scales that accommodate all sizes of patients in your clinic. And here's just again another chart that talks about what normal weight gain rates are, just for your reference, but again, we really track it and see what those trends are on the growth chart. Oops. So just to review a little bit, if you look at the picture on the left, both of these are showing some issues that could be in the way that they're being performed. So in the picture on the left, what's wrong in that picture? So you can see that they're using that floppy arm device on the scale, and you can see that the measurement is not going to be accurate based on where that floppy arm is falling in comparison into the height of the child. And so that's why floppy arm devices are not recommended, because it's very difficult to get the child in the right position and consistently, reliably, and accurately get a weight or a height measurement. And then in the second picture, you can see the problem is the child or person is wearing their shoes, and so again, the recommendation is that they remove their shoes prior to measuring the height so that there's consistency from one visit to the next, depending on, if not, the height of their shoes will be taken into account. And so what are some sources of measurement error? faulty instruments, and we've all been there when it just seems like the scales are off, and so having those calibrated is really important, and doing that on a routine basis to minimize those problems. Sometimes if you've got a stadiometer, if it's not sliding correctly or it's broken, that can definitely cause some problems. Casual techniques, and so if we're real strict one time and not as strict the next time, that can cause problems as well. Posture and movement, some of which, when we're measuring wiggly pediatric patients, is out of our control, but again, trying to be consistent with the way that we measure kids is helpful. And the other thing that sometimes helps is having certain stickers on the wall across from where you measure pediatric patients, so you can have them look at lined up vertically, so you can have them look at the orange if they're a certain height, or the strawberry if they're a certain height, if you've got stickers on the wall across it. Little techniques like that to distract and make it more fun for kids can also help a lot. Sometimes there is variation in our height at the beginning of the day to the end of the day, and so if you're really closely measuring a child's growth, that can be something important to remember as well, and so sometimes recording the time at which you take the measurement is important. If we measure only once, again, we may be off, and so that's why measuring 2 or 3 times and averaging those results is more accurate. And then sometimes recording errors can play a role. So did we mix up the numbers, or did we we recorded it in pounds instead of kilograms? And so that's why the consistency of measuring and recording in the metric system consistently kind of takes care of those things. Sometimes there's errors when the scale converts it from metric into the pounds and inches measurements, and so that's why the best gold standard is to measure in the metric system and record in that system. And then the lack of awareness, so just not realizing that all the important components to getting an accurate height and the importance of doing it consistently. And so the other thing is, when we're talking about consistency, is like sometimes if they're coming in not for necessarily a well-child visit, but just an ill visit, maybe we don't take off the shoes at that visit, or we don't check a height, we just check a weight at that visit. When we have those points on the chart and you're trying to track children's growth over time, from one time to the from one well visit to the next, it's really confusing if those aren't if you've got outliers. And so it's really important to, even when they're there, not necessary for a full weight check, if it's at all possible to be as consistent with this method as possible, so that all those points are as accurate as possible, and you can really get a true picture of how that child is growing. And so just a few questions to review. Should you always have the patient remove shoes and heavy clothing before obtaining the weight measurement, true or false? The answer is true, of course. Is it okay to just ask the patient how much they weigh and document that in the medical record? And specifically for children who are growing at a rapid rate, the answer is false. That is not the best way to do it. And then finally, you should have always have 4 points touching on the stadiometer when doing a height measurement. And which points are these? Is it A, B, or C? And the correct answer is B. Their head, shoulders, buttocks, and heels should be touching the wall on the stadiometer when you're doing a height measurement. There's also some posters that actually are available on the Blank website. So many of the slides in this presentation and the best practices were compiled by Dr. Jan Foote. She's a doctor of nursing in our endocrinology department, who did her doctoral project on best standards around accurate height and measurement. And from her work, they developed these, I think, really nicely done best practices guidelines that can be displayed in a weight room. I know in Central Iowa, in a lot of the clinics, they utilize these. So if you're interested, please email or contact Becca or I, and we can get you the link if you'd be interested in getting copies of these for your office as well. So that concludes our content section. Are there any questions that we can answer before I go back and play that first 5 video to end this webinar series? Any questions?
Any questions?
All right.
If anyone does have a question, if you please write it into the comment section at the bottom of your screen. Or if you'd like to, you can just go ahead and unmute your line and ask your question live.
Oh, great. So if there's no other questions, we appreciate any feedback you have of what was helpful, what was not as helpful, and how we can improve this in the future. And again, this will be posted on the IMS website and during CME credit. So if you had others that weren't able to join, they can access it on the website there. And then I'm going to go ahead and switch over to that first 5 video, and I'll let that play out. And feel free to read the conference whenever you need to.
There are many different body types, and nobody is the same for a child. Healthcare providers This video explains what those growth charts are and how they are used. First, we will talk about what normal growth looks like for children. These guidelines will help you know if your child is growing in the right way and in a steady pattern. Babies born on time should double their growth rate by 4 to 6 months. They should triple their growth rate by the time they are 1 year old. From 1 to 2 years old, expect children's growth to slow down. Toddlers gain 1 pound every 2 to 3 months. Growth patterns do not change much from 2 to 5 years. Most children in this age group gain about 4 to 7 pounds per year, and boys grow differently from girls. It's also important to know what children eat and how active they are affects their growth. Health problems can affect children's growth as well. Now let's talk about growth charts. Healthcare providers use growth charts to compare your child to other children of their age and sex. They also allow doctors and nurses to see the patterns of kids' height and weight gain over time, and whether or not their height and weight grow. If your child does not follow a steady pattern on the growth chart, your child might need some extra help to grow in the right way. If you've never seen a growth chart, here's what they look like. The left to right line usually measures age. The line going up and down shows what is being measured, such as weight or length. As these lines connect, they make a grid. Each growth chart has percentile lines. These percentile lines are created from information based on the growth of healthy kids. So we expect 50% of healthy children to grow at the 50th percentile or below. Most children fall between the outermost lines, but about 2 to 5% of healthy kids will naturally fall at, above, or below those lines, depending on the growth chart used. There are many different sets of growth charts. Those made by the Centers for Disease Control and Prevention, or CDC, are what your little ones will use most of their childhood. We will be using those same growth charts in this video. For babies and toddlers under age 2, we will use the World Health Organization growth chart. With any set of growth charts, different things can be measured, including weight, length for kids 0 to 24 months, or height for kids 2 to 20 years, and head circumference, or head size. On the growth chart, these will be based on the child's age and sex. So a boy whose weight for age is at the 25th percentile weighs more than 25% of other healthy boys his age. BMI for age for children ages 2 to 20 years and weight for length for infants and toddlers 0 to 24 months are 2 very important measurements. They tell us how well a child's weight and height match up. A child could be within the ideal ranges for height and weight on the growth chart. Those 2 percentiles are very far apart. The child may still be having problems growing. For example, a boy could have a weight at the 50th percentile, but if he's very small, maybe at the 90th percentile, his BMI for age might be too low. This would tell us if he's not getting enough calories to keep some fat on his body. Growth charts have an ideal range, but not an ideal percentile. The ideal ranges by age group are shown below. A child at the 95th percentile is not necessarily growing better than a child at the 25th percentile. Looking at it another way, a child whose weight for age is at the 95th percentile does not get a letter grade A, and a child at the 25th percentile does not get a
25th percentile would weigh more than 25 of those children. Let's look at some examples. This is a growth chart of a 5-year-old boy growing consistently at the 3rd percentile for weight. Many parents might worry this means their child is underweight because he falls below the ideal range of the 5th percentile. But he is growing consistently just above the 5th percentile in length and gaining weight at a steady rate. Putting weight and height together, we see this boy's BMI per age is very appropriate, above the 25th percentile. This is an example of a child who might be considered underweight, but is in fact growing very healthy and at a consistent rate. Now let's take a look at the growth chart of one more 5-year-old boy whose weight per age is at the ideal range at the 40th percentile. He gained no weight over the past year. The boy's height per age is high at the 90th percentile. For that reason, his BMI per age is below the 1st percentile, so he is underweight. You can see the child's weight per age across 2 growth curve lines. Small changes in a child's growth percentiles are very normal. Crossing 2 curves on the growth chart, like this boy, may indicate a growth problem. While it is helpful to know a little bit about growth charts, it's not your job to understand everything about them. Your healthcare provider can help you with that. Instead, it might be helpful to boil it down to patterns. Here are some patterns your healthcare provider looks for in the growth chart, along with what they might need. Good, your child is growing. Caution, your child is not growing. Caution, your child is growing faster than expected. Caution, your child is losing weight. Let's take a second to talk about height, as many families would like to see their child be the tall kid in class. It's a myth that children will grow taller faster with more calories and protein. In reality, a child's height is mostly controlled by the height of their parents. If the child is already growing well, adding more calories usually leads to more fat. It does not make a child grow taller at a faster rate. Children are born with a very good sense of the amount they need to eat to grow the way their body is meant to. Encouraging your child to eat more calories than they need can lead to eating issues and having too much body fat, or both. Another First 5 video will talk about how to help your child develop good eating habits early to grow in the best way possible. Some children are not able to meet the amount of calories needed for good growth. These children will often have a low BMI per age, or not have much fat on their body, have a small height on the growth chart, and may even have smaller heads compared to other kids their age. These children need extra help getting the calories they need. This is something that should be done with the help